Okay, it's 8:05, and I've been given the signal that we should get going. It is a distinct pleasure to have Dr. Morillo come speak to us. He is coming from McMaster University in Ontario, in Canada. He actually was born in Colombia, in Bogota, raised in DC, went back to Colombia, did his medical school there, then trained in cardiology and electrophysiology with one of the meccas of EPs in EP in Canada with George Klein. Then spent a couple of years in Richmond, Virginia, and went back to Colombia. And then his past decade or more has been back in Canada. Dr. Morillo has made very important seminal contributions in the field of EP. One of the first experimental models of chronic AFib induced by rapid pacing in animals was his creation. He's done also contributions in cardiac autonomics, and he's managed to also make contributions outside EP. That's one of the reasons we brought him here. He managed to create a research consortium in South America and succeeded in carrying out the seminal study in Chagas disease, which it shouldn't be considered as esoteric type of disease, since in Houston it happens to be endemic. Anyway, it's one of the reasons why we brought him here, because he could give us basically a perspective on a disease that we don't hear about, but we should, and we're looking forward to his contributions. Carlos?
Well, thank you, Miguel, for the kind introduction. I didn't pay you anything for that, but anyways. It's a pleasure to be here. And again, I'm an EP guy and an autonomic physiology guy, but I'm going to be talking about Chagas disease. And I'll tell you a little bit about the story about that. And again, I come from the mecca of evidence-based medicine, as you know, which is McMaster University. And this is our PHRI, Population Health Research Institute, is what they call today an ARO, an academic research organization. And we do clinical trials in over 170 countries in the world. We've randomized over 2 million people around the world in the studies that we've done. And I'm sure you've heard about the CURE trial, the HOPE trial, InterHeart, InterStroke, OASIS 1 to 7. You know, there's a long line, RELY, AVEROS. So we're pretty much a big clinical trial kind of group. And within that, we have a division of global health, in which we work both in rheumatic heart disease and other neglected diseases, such as Chagas disease. So when our institute director is Dr. Salim Yusuf, who's done some major contributions. So here's my research, my conflicts of interest, and these are mostly related with Chagas, and I have a bunch of other ones here included Café Colombia, because I'm Colombian, and one of my buddies from high school actually was the president of the Colombian Picking Coffee Association, and gave me some money to do some autonomic stuff on coffee. So as Mark Twain would say, I would exaggerate a little, but most of what I will tell you is the truth. So I'm going to go over, I think I got 45 to 50 minutes or something around that, over the following overview here. I'll talk a little bit about the epidemiology, the pathophysiology, what is the clinical presentation, how do we treat Chagas, in a couple of studies that have come out in the recently that I've been involved with, and what are the future directions and some conclusions. Now, how old is Chagas disease? Well, actually, this is from a friend that collaborates with us, Dr. Felipe Gul. And this is, on the right, you see this is from a mummy that was taken there in Peru from the Incas. And they actually did some DNA there, and they found that there was T. cruzi, which is the agent that produces Chagas DNA in this. So actually, Chagas is as old as 9,000 years. This is the gut of that mummy, and you can see a big megaesophagus there and megacolon, which is one of the clinical characteristics that some of the varieties of T. cruzi has. So that's a little bit of trivia, and a little bit of other trivia on Chagas disease, is that a very important guy in the world, it was Charles Darwin, apparently may have had or may have died of Chagas cardiomyopathy. Now, you know that Darwin did a lot of traveling around South America, and he actually wrote this in his journal when he was visiting the Patagonia and around the Pampas, and he just describes very distinctly these bugs that apparently had sucked his blood and probably led to Chagas disease. So there's a big discussion whether Darwin had or did not have Chagas disease, and I don't think we ever know unless we get some of his tissue and get some T. cruzi DNA. So how is Chagas disease transmitted? So we know the agent, and the agent, again, it's Trypanosoma cruzi, and this is a flagellate parasite, also known as American trypanosomiasis, because it was basically confined to Latin America and some parts of southern U.S. Now, the vector is this bug, and there are these tratomine insects. They're called the kissing bugs. And basically the way they transmit this is that they, at night they bite you, and then, they get bloated with blood, and they defecate. When they defecate, that actually makes you scratch your skin. And that's when you break your dermis, and that's how the parasite gets in. Now, some people ask me, well, I went down there and did some camping in Colombia, and I'm at risk of getting Chagas disease. And I said, no, you're more risk of getting Zika than Chagas disease, because actually you have to be bitten 1 million times to actually get that, and have to have some sort of immunodepression. Now, there's an acute phase in which you see this, the Romagna sign, which is not very frequently seen today, but there's still some acute Chagas, and then there's some domestic mammals that actually transmit the disease and are reservoirs for the different T. crucis. Now, T. cruzi is actually a challenge that, as I guess in honor to Darwin, it's evolved with time. And there's not only one T. cruzi. That's one of the problems. So these are what they call the discrete typing units, and there's about 6 of these, and then there's one that's confined to bats. And you can see that they have different both clinical presentations and geographic presentations. Now, that's important in when we started doing the trial that I'll discuss with you, this information was really not that available, because this is a more recent classification and may have some bearing on that. So, in the southern cone, it's more T. cruzi 5 and 6. In Brazil, depending on where you are in Brazil, it can be T. cruzi 2 or 3, etc. So this is distributed around. And the other challenge is that the bug, there's many bugs that actually have also evolved and become resistant not only to therapy, but to not only anti-parasites, but to the spraying that they use. So the cycle is that, as I told you, the bug that can be Rhodnius prolixus, these triatoma, they basically bite you, they defecate, and then, the amastigotes go into the bloodstream. And for reasons that we don't really understand well, they're very avid of tissue that is rich in autonomic innervation, like the heart and the gut, and occasionally the brain. Now, how much of a problem is this? And this has changed a bit without the years. There's a publication back in Lancet, and you can see that between the decades of 1980 and 85, it was estimated that there was around 15 million people around South America or Latin America that were at risk of Chagas disease or had infection with Chagas disease. Today we say it's around 8 to 10 million, and we can see that in some countries, and especially in the southern cone, where there was an initiative to spray the bug, they pretty much reduced the transmission of acute Chagas. But in other countries like, the Andean countries where I come from, Colombia, and these countries, because of other social unrest and political uncommitment, they never sprayed anywhere. So you can see that these rates have not changed. Now, these are the rates of seroprevalence in the population. So this is, you go and grab a bunch of population, take your blood, and then you do the serology. And for example, in Ecuador, up to 41% are positive to Chagas. That's a lot of people. And you can see here in Central America, and again, this is important because when you see a patient, you need to know where he comes from. What is the risk, the seroprevalence, and also what is the type of T. cruzi that he's going to have? Because that's going to probably guide you on to whether Chagas cardiomyopathy is a potential diagnosis or not. Because we know that the evolution of the disease is quite different among countries. Now again, the prevalence changes quite a bit. And you can see, for example, Bolivia is over, the prevalence in the population is over 5%. And if you look at, this is Argentina, anywhere between 3 and 5%. But if you look in Colombia, it's 0.99. But in the city where I used to work, it was like 12%. So it also varies geographically within countries. And it is a disease that creates a huge loss in dailies per 100,000. So it's a lot of money is lost by people that lose their job or die early because of this disease. So it's important to keep that in mind. do we have to care or worry about Chagas disease becoming something that are you going to be seeing anytime soon? Well, yeah. It's been estimated that in the States, there's around anywhere between 300,000 and 400,000 people with positive serology. But again, where do those estimates come from? And you know that migration is a hot topic in this country, and well, in every country right now with all that's going around the world. But you don't really know exactly how many people have come from all of these countries, including my country. So, and the people that migrate probably are at higher risk of having that problem. You can see that Spain, where Miguel is originally from, there's almost 80,000 people that have positive serology. So the problem is, why is it important to know this? Well, because if you're a woman and you have a positive serology and you have kids, your kids have an 80% chance of having congenital Chagas disease. If you don't detect that, and you don't treat that, those kids will evolve eventually to have cardiomyopathy, at least 30% of those. But if you treat them early, once they're born, you have a 100% chance of curing them. So it's an important public health issue that you need to take into account. Now, in the States, just in 2007, the FDA approved an ELISA test for donors. And you know that there's been some studies done in different areas of the States in which the people that actually donate more blood usually come from Hispanic countries. But we were not, and the same thing in Canada, we're not actually testing for serology in that population. So it's important to bear in mind that stuff. So looking at the global, there's a global systematic review on Chagas disease and prevalent among migrants. And you can see here a couple of recent studies in the States. One that looked at almost 32,000 donors, but a very low prevalence, 0.2, and 0.3 around here. So and these included actually pregnant women, which were about 3,200. So, and in Canada, again, same thing. So, how much of a problem it is? Well, we don't know. Looks like at least the seroprevalence in blood donors is low. But again, not everybody donates blood, and you may be underestimating this. Now, the other thing that's been happening, and that is interesting, and we don't really know why this happens, is what this shows here, and this is from this same systematic review, and these lines are the estimated prevalence in those countries of origin. Okay? And this is from Spain, and you can see actually compared to what they saw in migrants in Spain. And there's a bunch of series that have shown that actually the seroprevalence of people that have moved to some of these countries is almost 3 or 4-fold greater than the seroprevalence in the country of origin. Now, we don't really understand what is the dynamics of that, and you can see here that previous one, this is in Bolivia. So again, Bolivia is one of the countries that has the highest seroprevalence, up to 20%. But you can see here, it's almost 35%, and the country prevalence is about around 7%. And all these people that were in Spain had way above the margins that were identified in the country of origin. So these people probably had a higher risk of being infected and transmitting the infected to their kids, or just when they donate blood. And this is from people from Paraguay, similar things. So the prevalence has actually increased quite a bit. And you know that there's anywhere between an estimated number of people infected in the States, again, goes from as low as 38,000 to as high as 400,000. So when you have that range, what is the truth? We have actually no idea. But the fact is that there's no doubt that there is an important impact here in the States, and we probably need to get better data on the epidemiology of this. Now, this was just recently published in the American Journal of Medicine, and what's the clinical significance? Well, it was previously limited to Latin America, which is the leading cause of non-ischemic cardiomyopathy. And of course, with the migration here, it's the U.S. today is the 7th country in the Western Hemisphere with number of individuals that have positive serology. So it is a problem, but you guys, A, don't make the diagnosis, B, don't think of it, and there's not a lot of treatment that you can do. So it may be a public health issue here. How close is it to Texas? Well, this is a Texan horse down in Houston here that got infected, and this was published just this month. But on a more serious note, this is actually the map that was just published in October of last year in the Journal of Parasitology. This map of Texas, and these are all the places where they found triatom bugs that are native to this area of Texas, and that they actually pose a risk for autochthonous Chagas disease exposure. So there's been reports of autochthonous Chagas disease here in Texas, and this is the bug in case you see it anytime soon. Just crush it and don't eat it. Anyway, so the pathophysiology of Chagas is a little bit complex, and I'm just going to go through some of the stuff that we know. When I started doing the benefit trial, it was almost 12 years ago, there was a huge discussion and a huge debate on whether the parasite was really involved with this or this was more of an inflammatory response. As a matter of fact, some people thought that it was unethical to participate in the benefit trial, either A, because the drug had nothing to do, or B, because everybody needed to be treated. So that's what we call equipoise. So that's why we did the trial with the placebo control. Anyways, there's a lot of inflammation, TNF-alpha, and all these inflammatory stress creates some alterations that may lead to an increase in the parasite growth. Another fascinating thing about Chagas cardiomyopathy is a very unique model of cardiac neurocardiomyopathy. And there's been plenty of studies that have looked both beta-1 and beta-2 antibodies, as well as the muscarinic M2 receptors that are highly increased in this population, and probably some chronic exposure leads to downregulation. But also it creates hyperadrenergic state, which, as you know, one of the clinical hallmarks of Chagas disease is all these aneurysms in the apex and the inferior wall, and we know that these increasing catecholamines may lead to some subendocardial damage, especially in the LV apex, because we know that beta-adrenergic receptor density is higher in the subendocardium, and this adrenergic stimulation may lead to microinfarcts, fibrosis, and lead to that. Now, the thing with Chagas is that are we able to actually predict who's going to progress to the cardiomyopathy? And a long time ago, when I was back in Columbia, we did some studies looking at different markers of cardiac autonomic function, like baroreflex sensitivity and some other tests. And we did find that the people that were in the indeterminate stage, that I'll explain a little bit in a few minutes, that basically did not have any evidence of ECG changes or any cardiac involvement, already had some alterations in baroreflex sensitivity. The other fascinating thing in Chagas is VT, and you know that the epicardial technique was born out of doing VT ablations in these patients. Dr. Eduardo Sosa in Sao Paulo was the father of this. But we've done some other interesting things, because interestingly, in patients with Chagas that have 5 times more VT than ischemic cardiomyopathy, they rarely have syncope with VT. So we're trying to investigate that, and this is ischemic VT, and what we were looking at sympathetic nerve traffic. And you know that if you impale the peroneal nerve, you have a direct view of sympathetic nerve traffic. And we're looking at sympathetic nerve traffic doing simulated VT. So in other words, these guys all had a defibrillator. If you stimulate them at 150 beats per minute, you're basically simulating VT from the physiologic perspective. And you can see how the baroreflex sensitivity was not as efficient in the patients that had ischemic VT compared to those that had Chagas VT. And we looked into that. And we also looked at some of the mechanisms, looking at monophasic action potentials, both in the right and the LV, and you can see those little squiggles here that tend to trigger the activity delayed EADs and triggering this activity in VT, which is quite complex. So the pathogenesis of chronic Chagas cardiomyopathy has a number of issues, like the neurogenic disturbances, microvascular derangement, there's some autoimmune response, but these are all ancillary, and they are all dependent on this low persistent parasitemia. And that's been one of the challenges, because what happened is that most people said, well, you know what, if you already have cardiomyopathy, we can't detect parasite. So in the early 2000s, there was no way of detecting parasites in these guys, and the typical way of detecting parasites was obviously not going to be useful in a clinical trial, because I don't know if you know, but xenodiagnosis, what you do is you get in a little jar these bugs that I showed you. You bring those bugs to someone, get them to bite him, suck his blood, then you take those bugs to the lab, open their gut, and count the parasites. You're never going to do that within the context of a clinical trial. That's the way they would figure out if treatment was working. Now, I'm talking about the year 2002. So in 2000 or so, PCR came out and said, okay, well, we can actually detect DNA from T. cruzi that is circulating. And that's why these things change. And in the chronic stage, the parasitemia, as I'm going to show you in a minute, is very low, so may be undetectable by these methods. So we know that in these patients, there's a lot of things that are going on, but the low-grade parasitemia actually has a role. And you know that the natural history of Chagas disease is very, very slow. And you see that initially there's a very high density of parasites circulating. But as the symptoms progress, look at your parasite counts are very low. Now they're still there, but they're very low. And as cardiomyopathy progresses, and it's a very slow, insidious cardiomyopathy. So it takes only 30 to 40% of those that are infected are going to develop cardiomyopathy. And we don't know which ones are going to develop cardiomyopathy. That's the other challenge. So that's why we try to look at these in a long-term follow-up. It's hard to find outcomes in these patients because they have very few. So you know that there's an acute phase where apparently most people don't have nothing, a flu or something. Now there is about 5% that have what I showed you, that Riemannia sign, and have acute myocarditis. But most then go into the chronic stage. And the chronic stage has an indeterminate form and a determinate form. In the indeterminate form, you just have a positive serology. ECG, echo, everything else is basically normal. Now, if you do some more fancy testing, you may find some stuff like, if you do an MIBG, there may be some denervation or stuff like that. But for the clinical purposes, these people are basically asymptomatic and have no damage. Then you can go into the cardiac form, where you're going to have the ECG changes that I'm going to show you in a minute, or you have the mixed form with both megacephalus and megacolon, and that is rare and is mostly seen in the southern part of the continent. Now, Chagas heart disease is one of the most arrhythmogenic diseases, both AV block, sinus node dysfunction, and I don't know if you know, but the description of right bundle branch block and the left fascicular block came from Chagas disease. So these patients have a lot of ventricular arrhythmias, but unfortunately, even with preserved LV function, 50% is the mortality rate in these people by 5 years once you make the diagnosis of cardiomyopathy. So it's a huge problem, and I'm not going to have time to discuss whether ICDs or not work here, but maybe in the question period we can do some of that. Congestive heart failure is very important, and especially RV heart failure. And then there's the thromboembolic diseases, which you can see there. And this is classified by stages, and we published this a few years ago. I think it was 2 or 3 years ago in JACC, looking at the overview of that. So what happens with these patients? So pretty much they have a lot of ECG abnormalities. Right bundle branch block combined with left anterior fascicular block. It's not pathognomonic, but it's very frequent. They have lots of pathologic Q waves. A lot of these people are confused with acute MI. STEMIs, they come with chest pain, ST elevations, VTs. Take them to the cath lab. 90% of the time, you're just going to find big ectatic coronary arteries with slow flow, but no coronary artery disease. Now, we don't know exactly why that happens, but that's the clinical picture. Heart failure, syncope is quite frequent, and a lot of ventricular arrhythmias. And you know that most of the ventricular arrhythmias are fast VT, and more than half have an epicardial breakthrough. That's why the epicardial technique was designed there. Aneurysms that may be multiple, apical, and infrabasal are quite typical. And these patients also have thrombi, and the echocardiographic characteristics are quite typical of Chagas disease. And again, the classic right bundle with left fascicular block is pretty frequent and prevalent in these patients. Now, MRI can be used also to typify a little bit more. Down in Colombia and in Brazil, they use this to basically find the substrates for VT and try to do the VT ablations from that. So what do we know about how we manage these people? So once you're exposed to Chagas, you actually have either vectorial transmission is quite rare, transfusional is also rare, still congenital, organ transplant occasionally happens, and there's been reports everywhere, including here in North America. Either you have infection or not, you have acute infections, it's either symptomatic or symptomatic, and if it's symptomatic, you give the antiparasitic drug, and the cure is about 80%. Now, once you go into chronic phase, there's a lot of discussion of whether you should treat all of these people, and we'll look at that a little bit later. And then, 10 or 30 years later, you go into the chronic determined form, you have cardiomyopathy, etc. So how do we handle these, and what are the recommendations? The recommendations from some of the guidelines in South America There's no doubt that in acute Chagas disease we should treat, but again, there's no randomized trial that's ever been done, and there's no randomized trial that will ever be done. Not everything needs a randomized clinical trial to prove that the treatment works. Now, recently acquired infection, it's a little bit of a vague statement. What do we call recently acquired infection? If you look at the guidelines, it's mostly people, young kids or until 20 years old, people are treating these patients. The problem with the treatment is that we only have bisnidazole and nifurtimox that are both very toxic medications, so most people don't want to do that. Organ transplantation for sure, and a lot of discussion on whether these patients in indeterminate form and mild chronic cardiac form should be treated. Now, what do we know about some experimental data here? And this is from almost a decade ago, in which patients, this was a murine model, and what they gave them was they treated these patients, these rats, with bisnidazole, which is the antiparasitic drug, and you can see that those that were treated have a significant reduction in the parasite load. So one of the things that we've hypothesized in Chagas is pretty much what happens in HIV. You never get rid of the virus, so you're never going to get rid of the parasite, but as long as you drop that load that hits a threshold that produces so much inflammation and fibrosis, maybe you can detain, delay, retard the progression. So that's the thinking that we've been having for some time. You can also markedly reduce other pro-inflammatory markers, and you also reduce the percentage of fibrosis, at least experimentally, in these animals that had like early cardiomyopathy. Number of meta-analyses have shown that unfortunately you can see that in a disease that's so prevalent, there's only 3 very small randomized clinical trials in the early stages of the indeterminate stage, but nothing in patients that already had some sort of cardiomyopathy. And the markers here, the outcomes, were just looking at serology and other markers of autoimmune response, which look like they're all pretty good in favor of bisnidazole. But there is no data looking at long-term follow-up or looking at hard outcomes, even looking at echo or ECG changes. So in spite of that, the guidelines, again, continued to be quite controversial. So back in when I think it was in 2000 or something, I was at a meeting in Chile, and the faculty dinner was wine tasting. So that's a good thing in Chile. And I was there with Salim. So Salim, I met Salim when I was training in Canada, and for other reasons he knew. My father used to be the CEO of a thing called INCLIN. INCLIN was the International Network of Clinical Epidemiology. It was a thing that was basically funded by the Rockefeller Foundation, McMaster University, and University of Pennsylvania. And their mandate was to go to third world countries, train people like yourselves in clinical epidemiology, and try to get them to answer problems in their own countries with randomized clinical trials. So my dad gave Salim some money and stuff for the Interheart study. So he asked me, so how's your dad? How's it going? So what are you doing in Colombia? Why aren't you in Canada? I said, well, no one has offered me a job. I said, well, send me your CV. So to make the story short, in about 3 months, I was back in Canada. That was the time, and I don't know if some of you people have seen this series, Narcos. Well, all that stuff was happening in the city where I was. As a matter of fact, I was the chief of cardiology there, and I had 3 of my cardiology staff kidnapped at the time I left. One never came back. 2 had to pay a lot of money. So it was a good move to go to the cold, in spite of the fact that today it's minus 25 degrees up there. Anyway, so we came into the benefit trial that we published last year. We presented at the ESC at Late Breaking Clinical Trials. And basically what we wanted to do with the benefit trial was to evaluate whether bisnidazole would reduce mortality and progression in Chagas cardiomyopathy in patients that had early established cardiomyopathy. And we defined that by people that had some ECG or echocardiographic alteration. And as I'm going to show you, these were early people that did not have advanced disease. And we want to determine the effects of bisnidazole on parasite detection by conventional PCR and evaluate the safety and tolerability of bisnidazole. Now, again, you have to keep in mind that doing these trials is pretty challenging. First, I was doing this in Canada. I was sending the grants to CIHR, which is your NIH. And the first time I sent the grant, they told me, well, what do we care about Chagas disease here? Why should we give you $2 million for something that we don't care about? So, okay. So like after the 3rd iteration that I reviewed the grant, I kind of had a friend in Immigration Canada. I asked him, well, why don't you show me how many people have come from all these countries? And actually, it was surprising. In the 5 years before the grant, there was a huge amount of people that had come from these countries that may or may not have been exposed to it, but I use it as a way of leveraging the grant, and they actually gave me the money. Said, well, we Canadians, we're good people, so we're going to do this, save the world. Anyways, so what we did was that we randomized these patients with chronic Chagas cardiomyopathy between 18 and 75 years. They had to have 2 positive serology tests, and they have the typical ECG abnormalities. They were randomized to benznidazole or placebo. Now, this is another. There's a lot of stuff that happens within these trials that you would never anticipate. So the drug benznidazole was produced by a big company called Roche, but it's about $5 for the treatment, so it's about 60 days. So they decided, you know what, we're not making any money out of this, so we're dropping the license, and you can do whatever you want. So in the middle of the trial, we ran out of drug. So a Brazilian company says, well, okay, no problem. We'll make the drug. Okay, great. So they come up and they do the placebo and they do the drug, and then we realize, hey, you didn't do the drug scored. So we can't calculate the 5 milligram per kilogram dose. Oh, sorry. Well, that's all we got. So in the middle of the trial, you have one drug that first we don't have any PK, pharmacokinetics, nothing to know if it's the same thing as the Roche drug. The second thing is that now we can't give the dose of 5 milligrams per kilogram in 60 days, but now we have to come with something up to try to give the total dose that was the same thing. So we came with a scheme in which we kind of distributed throughout the weight, and it was more or less 60 to 80 days. But those are challenges that, in the end, we did do some data that actually shows that both drugs actually worked the same or didn't work the same for what matters. We followed up these patients up to every year for a mean of 5.4 years, but 80% of the patients were followed for 7.5 years. We paid $400 for the 10-year follow-up. And we lost, as I'm going to show you, very few patients. The primary outcome, again, was heart outcomes, and that's what we wanted to look at. Again, this was a network that we had patients in El Salvador, Brazil, put almost half of the patients, Colombia, 500. Colombia put 500 patients, but one center put 480 patients. So I know the guy, so I said, because when that happens within a trial, you start getting a little bit worried. Okay, is this really true? So I went down to where this guy worked, which was near Bucaramanga, and the guy had a Jeep, and he would go out every week, and he would drive 12 hours, take his echo, do echoes, serologies, and randomize people. And he would go every other week to follow them. He didn't lose a single freaking patient in 10 years. Seriously. This guy recruited 480 patients. And just because of that, I put him as one of the authors of the paper, because that's really a labor of love. About 357 in Bolivia, and then again a single center, and 559 in Argentina. We had about 50 centers around Central and Latin America. We had 3 PCR core labs. That's again the other thing. So I write this really nice grant where I say, I'm going to do PCR. But then I discovered that actually, you know what? It's like, homemade kitchen PCR. It's nothing that's been standardized, nothing like that. So then I have to, convince the WHO, and they have a division called TDR, Tropical Disease Research, to give me some money to create this workshop in which these people actually are going to standardize this technique that I already said that we're going to be using. Anyways, it's a lot of stuff that goes on into doing this kind of trial. And that's, you already saw that. And again, interestingly, 84% took more of the target dose of benznidazole, which was very good. We only lost 15 patients, which is remarkable, I have to say. So we had 99.5 complete follow-up at the end of the trial when the data was analyzed. And, I guess that's one of the reasons why we made it to the New England Journal. Now, the study drug compliance, even in spite of the fact of being, as I'm going to show you, a sort of negative trial. So you can see here the number of patients randomized and the patient compliance, which is very good, and drug interruptions were not that high and very lower compared to what had been reported in the literature, and drug was restarted in almost 5% of the patients. Now, who are these patients? Again, most of these patients were in New York Heart Association Class 1, which again, it was sort of early cardiomyopathy. Only 2.6% or so had previous heart failure, systolic cardiac arrest 1.3%, some VT, again, very few, atrial fib about 7%, and a pacemaker or an ICD in about 14%, and syncope in about 8.5%. Now, the other thing is, again, and that's something that we need to review in a little bit more detail about these patients, is the management, because you can see that even though most of these, and remember that we started this in 2002, and almost 20% were on spironolactone, which in those days wasn't really an indication, a class 1 indication for New York Heart class 1, because of the anti-fibrotic effects that spironolactone has. ACE inhibitors, about 40%, ARBs, another 10%, digoxin, 10%. Very low usage of beta blockers. That's one of the clinical markers of Chagas disease. You get someone with Chagas disease and heart failure, he's never going to be tachycardic. These people do not do tachycardia because of the autonomic dysfunction that I showed you and sinus node dysfunction. So there's a huge fear in giving beta blockers to these people because they end up being paced. Now, we were doing a trial called Charity in which we were randomizing to beta blockers or not, and we have some data that hopefully will get published soon. Now, amiodarone, almost 20%. And this is an interesting story, as you will see. I will show you a little bit later what was going on. So we looked at the PCR after treatment, 60 days. And then we looked at the PCR at 2 years and at 5 years. But remember, not everybody was PCR positive. So this is only on the PCR positive people that were about half of the patients. Again, remember that even with PCR that is highly sensitive, about half are going to be negative at PCR in spite of having the disease because those peaks and valleys that you have. And we didn't have a lot of money, so we couldn't do 5 PCRs to make sure where was that threshold. So we only were able to do 1 at each time point. Now, this is the overall data, and you can see that at the end of treatment, well, there was some good effect, but still, placebo was still pretty high, so what does that mean? At 5 years, this kind of dropped a little bit. Now, in Brazil, there was a good response early on, but again, it kind of waned off. And in Argentina and Bolivia, so why is this by countries? Because in Brazil, predominantly it's T-cruci-2, Argentina and Bolivia, T5-6, and in Colombia, T1. And you can see that in Colombia and El Salvador, everywhere else, the response to PCR was pretty much null. So, of course, the next question is, okay, how does this compare with your clinical outcomes? And again, well, the disappointment in which we didn't really see, and this is up to 7 years, you see that the curves are almost crossing over again between benznidazole and placebo. There's no difference. Now, this created a lot of discomfort among the investigators in some of the other countries because they had betted that this was going to be the answer to treating Chagas cardiomyopathy. And we looked at, again, at the components of the primary outcome, and you can see that actually this was a study in which there was a 17% death rate, which is pretty high. There was also a lot of heart failure, about 10%. Not a lot of stroke or cardiac transplant or sustained VT. But anyways, these were hard outcomes, and there was no difference in any of the outcomes when we looked at them in the overall population. When you look at the subgroups also, again, you see here Colombia and El Salvador. And again, this created a lot of discomfort also because if you look at this, it's kind of touching the line there. So the Brazilians were, it works in Brazil. You can't imagine the arguments I had to have to say, no, it doesn't work in Brazil. Come on. Look at the interaction p-value. It's like huge. So there's no interaction. Means it doesn't work. But, that cost me a couple of friends down there in Brazil. So, anyways. But one thing that is interesting is that fair to say that both in the placebo and the benznidazole group, the event rate is way higher in Brazil compared to the other countries. Why is that? Well, it's T-cruci-2, which is different from T1, because you look at Colombia, the event rates are way lower, same as Bolivia and Argentina. So it doesn't work because the event rates are lower, the parasite is different, we don't know. Having a positive or a negative PCR at baseline didn't make any difference. Being old or young, male or female, there's been a lot of studies in Chagas that show that being male is a risk factor. We didn't find that. We looked at some severity scores, and I'll show that a little bit later. Right bundle branch block with fascicular block, whatever. Everything negative with one exception, amiodarone. Mudorone had a huge interaction. Look at these. By 5 years, the placebo group, those that were not on amiodarone, half of them had died or had an event. That's a huge event rate. Now, any takers on why amiodarone did that? Well, there's some data actually that amiodarone has anti-T cruci activity. So we looked at that, and we looked at the PCR, but there was no difference in PCR. Now, again, we have very few samples, but we're looking into this interaction a little bit more in detail. That may be the benefit 2 trial, because maybe if you give benidazole and amiodarone, maybe that actually has some interesting interactions. Now, adverse events, again, well, obviously were higher in the benidazole group, but they were really lower compared to what's been reported. In the literature, permanent discontinuation is about 50%. So we only got about 13.4% because we had a very tight protocol on how to deal with these things. Neutropenia and all of these other adverse events were quite low. Now, the other interesting thing was the parasite load, trying to keep in line with that theory. Okay, if you drop the parasite load, maybe we are doing something. Let's look at that. And we've had significant arguments about this. End of treatment, if you see with the active treatment, there's a marked reduction in the parasite load, but then it kind of creeps up and then goes down. Is there reinfection or not? Most of these people were living in urban areas, so reinfection is very unlikely. The fact is that we're looking at other inflammatory markers to try to explain this. And we also know that this is from one of the sub-studies that we'd already published. The parasite load is different. Now, again, this is fascinating and kind of goes in reverse of what we were thinking. I already showed you that the highest event rates were in Brazil, but they have the lower parasite loads. So I don't know how to explain this really. So the fact is that all of our hypotheses kind of are going on the wrong direction. So maybe that means that, well, maybe our primary hypothesis was wrong. Maybe we have to go back to the drawing board and rethink exactly what is going within the pathophysiology of Chagas. Now, we created this benefit-risk score looking at some of the markers that we had done, multiple regression analysis, and we found some of these that were quite able to discriminate the patients that were going to have problems. And then we looked at something interesting. If you look, these are the patients that had a low score, because one of the criticisms is, well, you know what, you're already way too late for treatment. People you treated were already way too advanced. Okay, so let's try to qualify them and characterize them by this risk score. And these are the ones that had a low risk score, and these two curves superimposed, so that's why you only see one. If you had a score of 0 to 9, there was no difference between benidazole and placebo. If this was true, you would see the benidazole group respond better because they're in an earlier stage. Now, also fair to say that by 3 years, 50% of those that have a high score have actual events. Now, this may not help us in the sense of what to do regarding benidazole, but remember that only 50-60% of patients were in ACE inhibitors, only 30% were in beta blockers, and other stuff that maybe we need to work more to try to prevent some of these events that were basically heart failure and cardiovascular death, and these are the ones related with death that pretty much show the same. So is there anything else that we can do in Chagas? And there's been some research looking at that. So let's forget for a moment those that already have advanced disease, quote unquote, and go into the indeterminate stage, which is the vast majority of people are still in the determinate stage. So in other words, positive serology. Now this study that was published from a group in Spain and Barcelona, to be more precise, they randomized a small proportion of patients. There's a phase 2 study, so that's not too big. 79 patients were randomized to 3 groups. One, there was benidazole. Another one, there was posaconazole. And posaconazole is an antimycotic, and just because of serendipity, once there was this patient that was for a transplant and had the severe fungal infection and also got reinfected with Chagas, they gave him posaconazole and they wiped out all the parasites. They said, oh, wow, this may be a drug that may be potentially useful for Chagas. And then, a low dose and a high dose posaconazole. Again, very few patients, but the bottom line is that they looked at treatment failures, and very few treatment failures, well, about 40% on benidazole, but more on the drug that was both the high and the low dose posaconazole. In other words, only 10% actually responded to or 20% to the drug. So the drug didn't work that well. DNDi, which is an organization, NGO, that's Drug for Neglected Diseases, has been very involved with this, as same as Medicine Without Frontiers. They did this trial in Bolivia, and they randomized about 270 patients to 4 different groups to this compound that is another azole, and they basically couldn't find any differences. Now, the ongoing projects are Stop Chagas. This is the one I'm a PI, and I'm just going to show you some stuff here. Fexnitazole and other trials that are ongoing. And I can't say much about this, but this is the design. Posaconazole, placebo, posaconazole and bisnitazole at a bit of a higher dose than bisnitazole alone. And if you want to know about this, you should go to Late-Breaking Clinical Trials in Chicago, and I'll be presenting the data there and hopefully publishing in one of the top journals. So what's going on with Chagas is that we really, in 50 years, there's been really no drug development. Because half of the problem is that we don't really understand the pathophysiology, as I showed you from what we had on all those hypotheses. So these trials, Stop Chagas, you got to wait until I present the combination. But the new compounds, they've all been negative. So there's a lot of hope on Stop Chagas to see if that's the way to go. There's a lot of compounds that are being used, and there's amiodarone here on top of the list that actually has a lot of crucipain activity. And some of these drugs are being tested to see, and including just enalapril has a very high anti-T cruci activity. So maybe combination with this, with bisnitazole, that appears to be effective, at least in the earlier stages, in wiping out the parasite, may be something to be done. So guidelines have not changed in spite of what we've done. But again, people interpret stuff in a funny way. So I did a survey last week with all my investigators in benefit. And so what are you guys doing with the guys that were in placebo? I said, well, we're treating them all. So what are you talking about? The trial didn't show anything. We followed these guys for 7 years. Well, what else should we do? Well, I don't know, but why are you treating them? Well, it's cheap. Yeah, well, again, medicine, evidence-based medicine sometimes doesn't sink in as one would like. Now, there's a lot of efforts in trying to identify the selection of new drugs and where should we go. Should we actually look at other things? And we are doing some sub-studies looking at the genotypes of the Trypanosoma cruzi, and maybe the genotypes are also the ones that respond better to therapy. Maybe some inflammatory profiles, and this is data we've published previously from Benefit, in which we've shown differences in the IL-17 and IL-N gamma response to treatment and to placebo also, and looking at those that have cardiomyopathy and those that don't have cardiomyopathy. So maybe a biomarker is the way to go. We've also been looking at other biomarkers like matrix metalloproteinases, and we've also published this recently. And you know that matrix metalloproteinases are very important for the contractility of the heart. And we did a correlation with echocardiography and SPECT, and there's an important correlation here. So maybe a combination of markers will be the response. And again, there's a huge project looking at genome-wide association study in patients with Chagas cardiomyopathy, trying to identify who are these people that actually are going to progress to cardiomyopathy and eventually may respond to treatment. And we've been involved with some of the polymorphisms that look at both inflammatory response and also contractility response, and are working on that. So just a word on ICDs. Those that know the topic, there's a huge debate on whether ICDs are actually good. There's a group in Brazil that says that actually ICDs in patients with Chagas kill more patients, because these guys get a lot of shocks, and you know that shocks actually are associated with increased mortality. So we're doing a meta-analysis, and we're going to do a trial looking at that. So in Chagas disease, there's been, like, paraphrasing Gabriel Garcia Marquez, almost 107 years of solitude. The disease was described by Chagas back in 1909, but this is the first big trial, was the one that we just published, with almost 3,000 patients. And we are kind of working with other drugs to try to figure out what's going on. So trypanocytal treatment in Chagas disease does reduce the parasite load, but it's not parallel with significant reduction in primary outcomes. So should we maybe, again, we're maybe naive in the sense that we treated these people for 60 days, and these people have been infected for 30 years. Now, if you look at other infectious diseases like TB, leprosy, stuff like that. These people usually get booster doses every year. So maybe that's our next step. We also found a risk score that failed to identify where the patient at lower risk would derive further benefits. We're working on the parasite load and the genotypes, and definitely newer agents and biomarkers are needed. And this is the institution back in Colombia where I did most of this stuff, and all of these fellows that used to work with me down there. It's sad to see that 90% of all these guys are not in Colombia. Well, it's good mentorship because they're all either in Europe or North America, but none of them stayed in Colombia, unfortunately. And this is my other institution, PHRI, that actually helped us do this trial. Thank you very much.
So, Carlos, that was a heroic effort to conceive the trial and take whatever it took you. Saying that it was heroic to conceive the trial and carry it out after 10 years and several thousand patients. So if I understood correctly, getting rid of the parasite does not change the progression of the disease, right? To put it very, very simply.
Yeah, well, yes and no. It's not as simple as that. Let's say that, remember that we only had one PCR per time. That's the limitation. But having said that, what I would translate in this different way, using the treatment that we used, that was one course of treatment for 60 days, did not change the course of the disease. That's the spin.
Okay, so would there be any role of retesting the patients that did well and retesting the patients that didn't do well to see if there's a correlation with regrowth or resurgence of parasite load?
Yeah, it's a good point, but remember that in the forest plot that I showed you, there was many things, but among those were positive PCR or negative PCR at baseline. It didn't discriminate anything. So is it the parasite or not? You see, again, this has been a very sensitive issue for many of the investigators down there in South America that are really into the parasite has a lot to do with the pathophysiology. So we've been a little bit cautious in our conclusions. Now, I have to say that maybe what we need to do is improve the overall treatment of heart failure and maybe pulse doses of benidazole at a lower dose that actually don't produce so many toxic effects may be something that we would be doing. We're debating on whether we should do some passive follow-up on these people, which in my mind, after 7 years, they didn't show anything. Probably not. Maybe we should re-randomize some of these to something like that.
Now, you briefly alluded, very, very briefly alluded to MIBG scanning. It's something we've been interested for other reasons, and I think we have it available, I think. Is this something that you could kind of test as the disease progresses and guide therapy, perhaps? Not that we have a specific therapy for cardiac nerves, but...
Yeah, we've thought about it, but again, remember, we're doing this in South America, so unfortunately, MIBG is not that available, and it's expensive technology. And to do it in, 3,000 patients, I'm not going to be able to do that for $400 per patient. But yeah, no doubt that that's why we're trying to look for other clinical or echocardiographic biomarkers and other inflammatory biomarkers that can actually identify these people so that we can do therapy appropriately, guided therapy.
Thank you for a wonderful talk. Actually not by design, but this fits nicely with heart failure awareness and cardiomyopathy, bringing down an EP expert but a Chagas expert. It's just a wonderful overview. We see a lot of advanced heart failure. I have a fairly robust initiative for heart transplant, and we always talk about screening these patients. There's much more awareness, especially in border towns where we have patients that come from South America or travel. So my question to you are, in your study benefit, there were 2 serologic tests to get in.
Yeah.
And so for detection, what you recommend, and then importantly, if you can comment on what treatment you would offer on the back end. They're going to get immunosuppression. We'd be interested in the parasitic load response and then disease. And so what would treatment be and how would you follow them? So what would you recommend in advanced heart failure center like ours?
Yeah, all good points. So there's a lot of data, and actually the test that the FDA approved and what CDC is recommending is that serologic test that you all now have a kit here. And you can do that and then do either an ELISA or any other IFI test. You have those two, your diagnosis is pretty certain. Now, other people are starting to recommend PCR also. And there's some effort after the trial that we did with Merck, the stop Chagas. There's going to be a commercial PCR that's been validated. So hopefully that will come in the next few years. So once you have two of those tests, you do have Chagas infection. Now, that doesn't mean that you have the disease. At least you're infected. So you're in an indeterminate stage. Now, the guy that comes for a transplant has a positive serology, and you're going to put him on immunosuppression. Guidelines recommend treatment on those patients, and treatment should be bisnidazole, 5 milligrams per kilogram throughout 60 days, and then check with PCR. As the PCR reactivates, you need to treat again. Those are the recommendations.
Yeah, thank you for the overview, and I think I've seen a couple of studies, one from Baylor showing the prevalence and local transmission in Texas, and I think I agree we probably don't pick it up as much as we do. I have two questions, one focused on the pathophysiology, and maybe I missed it, but there is evidence of amastigote infection in the cardiac cells.
Yeah.
But in the chronic stage, is it the immune system effort to kill the cells that makes the fibrosis over a period of time, or is it an antigen mimicry that also happens? And in that context, how do you factor in immunosuppression along with anti-parasitic medications?
Yeah, well, that's $1 million question because we don't really know. Now, we do know that when you look in the chronic patients and you actually look at the parasite, they have active mastigotes within the cells. But they also have a severe inflammatory response that surrounds that. Now, experimental studies have shown that if you get rid of the parasite, you get rid of the inflammatory response, and then you delay the progression of the cardiomyopathy. That's why we've said, okay, let's try to reproduce this in humans. Now, again, experimental models always use a really high dose of infected parasites. So that may be one of the differences. And these, although they're chronic models, they're, 6 weeks or something like that. That's part of why we're trying to see if there's actually other biomarkers that are telling us whether this is more of an inflammatory response. And maybe, and I didn't have time to go over all the data, but there's been some studies in the beginning that were actually using allopurinol to treat these patients. The first studies in Chile, Dr. Abt, and in Peru, were actually randomized studies of itraconazole and allopurinol. And they actually showed that they reduced markedly the parasites and the inflammatory response. So it's hard to, what's the chicken and what's the egg? The bottom line is that whatever we did was not enough. And maybe it was enough because maybe you really need to wipe out the parasite out of the face of the body, or we need to do a different approach that is more immunomodulatory.
My second question is more in the study where you saw worse outcomes in Brazil. How do you factor in for lifestyle differences? I'm sure Brazil is a party town compared to other places. Impact of alcohol, other things with cardiac outcomes, and is that factored in the study?
Again, there's not enough time for all that, but yeah, sure, we did it just as an analysis for. And again, I couldn't show you everything, but we actually have a very detailed CRF in which we asked what was the income, what was the housing type, alcohol consumption. It's more or less than Carlos, and that was the question. So, anyways, but we do have all that information. I can tell you that 80% of the patients in Benefit had less than 8th grade education and were in a very low income bracket. Now, we did some further analysis trying to tease out if, this is just poverty and you're malnourished and this is what happened, and, doesn't seem to show a lot of signals there. But remember, once you start doing subgroups and subgroups, my father used to say you can torture the data until it confesses, and it will confess whatever you want it to confess. So you got to be careful once you do too many sub-analyses if they were not predetermined.
Thanks for a great talk. My question is, in areas that are endemic, such as the ones that you did your trial, when you have a positive ELISA or positive PCR and you have a cardiomyopathy, are there any efforts to make sure that you're not diluting your samples with other dilated cardiomyopathies, genetics or viral myocarditis, et cetera? Since if they don't have, for example, the classic apical aneurysm, how do you ensure that it truly is Chagas that you're treating?
Yeah, that's a good question. I think that the main issues are the typical ECG changes. You're not going to see a lot of the right bundle with left fascicular block and all the conduction disorders, plus all the contractility disorders. Remember that you had to have two serologies plus 2 ECG or echocardiographic alterations to be in the trial. So are they 100% sure that these were all Chagas? I can tell you that pretty much so. Viral myocarditis probably doesn't have that course. And again, I can't tell you 100% for sure. We didn't do any viral antibodies, but did we look at coronary artery disease in every single patient? No. Again, some of these trials you have to be pragmatic, and this is a clinical diagnosis. So
yeah, I mean, not as much a criticism of the trial, but just in general for knowledge and for us when we see patients. I mean, have there been any studies that have looked at biopsies and seen the incidence of Chagas?
Yeah, it's very hard to find the bug in a biopsy. Yeah. Remember, I already told you that even doing PCR that looks at the DNA of the bug, 40% are still going to be negative. So because one of the dynamics that Chagas has is that the parasite fluctuates the amount of parasite that's circulating, but it's always at a very low threshold. So, of course, but again, clinically, acute presentation, some, viral symptoms, stuff like that usually helps out. And, of course, a place like here, you can do all the other markers for viral myocarditis to rule it out. And I can tell you that there's a lot of case reports in North America. These patients come with angina and typical ECG change. Everyone gets a cath. And all the coronary arteries are big, ectatic, and just slow flow.
Okay, thank you for that wonderful talk. You mentioned about 80% maternal to neonatal transmission. For the babies that are born with this condition, is the progression more rapid? Is there a difference in how they manifest themselves and how you manage them?
Yeah, good question. Yeah, apparently it depends also on the type of a strain. So apparently T. cruzi 2 is more aggressive. But there's pretty much consensus, and the guidelines actually mandate treatment in all these kids. So we don't have a lot of these kids that have progressed, and that's one of the places in which public health has actually worked well, in which all these kids are being treated. And again, one of the challenges has been to create an oral bisnidazole presentation. But they just crush the pills and give them the bisnidazole. And kids actually tolerate higher doses.
So are all pregnant women screened?
In South America they are. There are screens, particularly if they come from an endemic area. If you were born in Bogota and have lived all your life in Bogota, you're not being screened. But if you were born in 100 miles from Bucaramanga, for example, all these people, we have maps in each country of the endemic zones.
Enjoyed very much your talk about the disease that we don't usually think about all the time. And congratulations for your efforts. I mean, this is amazing work. Question to you is, are there any new series of autopsies that would relate your PCR and other markers to what really is going on? Where's the virus? Where's the organism? Is there still a load in the myocardium? Because if there isn't any, I mean, I know it could be a small series, but if there isn't any, what is the postulate mechanism of progression of disease?
Yeah, well, thanks, Bill. I think there's a couple of things that there are some newer series that have looked at, and especially the group in Sao Paulo. Dr. Higuchi has done a lot of this research, looking at autopsy and PCR, and there's big correlation. There's still a significant amount of parasites and the mastigotes in the myocardium. But again, I think that what we don't understand exactly is the interaction between the autoimmune response and the parasite. We still are at odds there, and I think that in a sense, benefit makes us rethink a little bit about that. Now, having said that, I wouldn't have much doubt of getting rid of the parasite in those that are in the indeterminate stage. Because, if the drug actually gets rid of the parasite, well, maybe you won't have that chronic progression at the later stage. And the challenge is that, well, it takes 20 to 30 years to manifest. Which one is the best biomarker to follow those people within 10 years to figure out what's going on? And we're working on that with different biomarkers that we're trying to figure out which one is, because it has to be reproducible, relatively cheap, not too complex to do. In other words, to be able to include within a clinical trial or at least a long-term epidemiologic follow-up study. It's basically, if it's T. cruzi 1, you're going to find it in the heart. That's it. T. cruzi 2, depending on the strain, you're going to find some on the gut, mostly esophagus and colon, and very rarely 5 and 6 go to the brain. But the rest of the tissues don't get a lot of this.
One quick question related to your risk score and the patients with lower risk score having the same events as placebo. I was thinking, if you follow those patients for a longer time, is there any plan to try to do that, to try to understand if you catch them early? Because I would expect those patients to have fewer events in your follow-up time. If you follow those patients for a longer time, do you think that will change? Or?
Well, again, good point, but pretty unlikely. Again, there's the biology of the dynamics of follow-up. If these curves, when you saw the event rate was less than 2% per year, and these curves go up to 7 years, and they're superimposed. So how long do I have to follow them up? 40 years? I'll be retired and dead. Not because of Chagas, but because of trying to follow this. Now, I understand that it's a good point, but again, if you actually do some prediction models with time, you're going to realize that your event rate is going to be so low that it's not worth doing it. Plus, it's not going to answer any questions in the sense of, should I treat those people? Because they're at very low risk, and it's probably more of a natural disease progression than related with the parasite. Yep.
One quick question also. I'm assuming that everybody that gets infected does not have the same course. It's one of the things that you emphasize. So you could wonder also about genetic predispositions. So would it make sense to take a sample of the people who do very well on their own and the people who don't, and look for, now that we can do a lot of genomic expressions of genes, and see whether there are some issues there that could potentially also throw some light as to what the next chapter should be.
Yeah, I agree. That's and I showed some of that at the end. I was kind of rushing a little bit because I was kind of running out of time, but some of the data that we've looked at is looking at some of the polymorphisms and some of the macrophage kind of response genes, or the IL-8 and 19, the metalloproteinases, and we've actually seen that people that don't have a polymorphism in those genes actually very rarely progress or progress very slowly. So yeah, that's the next step, is a combination between genomics of the gene of the parasite and of the host, because it has to be an interplay between host and the parasite. Okay, fantastic. Thank you again, my friend. Thanks.